This is Dr. Michael Miro from Fort Wayne, Indiana. I represent Parkview Health System and I'm an electrophysiologist there. I want to demonstrate today to you a iPad, iPhone app that was developed by Heart Rhythm Society to educate members, but more importantly, clinical care team members such as nurses, cath lab staff, on the indication for ICD implant for primary prevention of sudden death. Some of the background: several members of the Heart Rhythm Society worked on this based on a educational poster that had been developed at an institution, and we refined it over time in order to try to create an application that would be interactive and educational to educate everyone not only on the guideline but more importantly the CMS waiting period, so that there's compliance with the CMS waiting period. So shown here is an iPad 3, and we've downloaded an app from iTunes which has the HRS logo, which is shown here. And if you have launched that app, which you had downloaded, which is free by the way, it shows the screen here, and I'm going to show you the full protocol, which is an overview of this tool. So this tool was developed, as you know, to help members and part of the cardiac care team address the public health problem of sudden cardiac death and identifying people who might benefit from an ICD. Sudden death affects over 350,000 individuals a year in the United States, with 1,000 patients per day dying suddenly. These patients frequently present to a hospital setting and need optimal medical therapy, but then need to be protected during a waiting period. So now I'm going to show you the interactive protocol shown here. Let's walk through a couple scenarios. So to the left is a protocol that addresses ischemic cardiomyopathy, and to the right are non-ischemic cardiomyopathy. Let's say the patient is in the hospital, is found to have an ejection fraction of 40% after an anterior myocardial infarction. The patient did not receive a PCI or CAB, but was treated medically, since that individual may not have been a candidate for revascularization. So they've had the MI. They're placed on optimal medical therapy, which would include beta blockers, ACE inhibitor therapy, and aldosterone antagonists, and they're released from the hospital. This signals to you when you should have the patient return for reevaluation of ejection fraction on the date of June 17, 2013, which is a 40-day waiting period. And let's hypothetically propose that the patient had an EF of less than 35. Well, they are a candidate for a primary prevention ICD, and if you happen to be a general cardiologist using this application, you would want to refer this patient to a heart rhythm specialist for consideration of an ICD. If the EF is between 36 and 40, then that group of patients need further aggressive risk stratification by a heart rhythm specialist, since they certainly have significant residual risk and may be in need of an invasive electrophysiologic study based on the presence of non-sustained VT and a low EF, and would benefit from an ICD. If their EF is over 40%, then they should remain on optimal medical therapy and followed carefully and undergo periodic monitoring and other risk stratification. Shown at the bottom is a summary of the protocol. So let's go back and show you another scenario. Patient has an EF of 40. They have acute MI. Let's say they have an anterior MI, but they underwent revascularization. Date of MI is today. And they underwent revascularization, let's say with a coronary stent, and it signals to you that the patient should return on August 6, 2013, which is a 90-day waiting period, which is not a guideline. It is a CMS mandated waiting period. And just to reiterate that many of the recommendations in this are based on education around the CMS waiting period and is not a guideline, it's a suggested pathway. During this waiting period, the patient returns and now found to have an EF of 35. An ICD is indicated, so they're either referred to a heart rhythm specialist or receive an ICD if you are a heart rhythm specialist. If the EF is 36 to 40, again, further risk stratification, EF greater than 40, they're continued on optimal medical therapy. And at the bottom here is a summary of those recommendations. So let's go through another scenario. Patient has EF, has non-ischemic cardiomyopathy, has an EF of 35. They're on you see the patient in consultation at the hospital. They have an ejection fraction, let's say of 30%. Newly diagnosed, you get them on optimal medical therapy. You consider them for not only institution of optimal medical therapy, but the use of a wearable cardioverter defibrillator if you feel they're at very high risk for sudden death. And if you're a general cardiologist, you would want to have a heart rhythm specialist look at the patient in the hospital. They should return on August 6th of 2013 for reassessment of ejection fraction. And indeed, they do that, and the ejection fraction is 35%. An ICD is indicated assuming their life expectancy is 1 year or greater. And if you're a general cardiologist, you should refer the patient to a heart rhythm specialist. The EF is over 35%, then the patient should be carefully watched, maintain an optimal medical therapy, and periodically undergo further risk stratification, such as monitoring to see if you could detect non-sustained VT, or use other tools. In our institution, we use T-wave alternans to further risk stratify patients. And shown here is a summary of the details of that pathway. So let's take a third scenario. Patient has an ejection fraction less than 35, non-ischemic. They have cardiomyopathy, but they've been on optimal medical therapy, so let's say for 6 months, and they return to see you, or you are seeing them in your office in consultation, and they've been on optimal medical therapy. You reassess their ejection fraction, it's still 35%, so they're indicated for an ICD at that point, since you have documented they've already undergone the mandated CMS waiting period, and so an ICD is indicated assuming their life expectancy is greater than a year. So that summarizes the use of the interactive components of the app. As you know, the Heart Rhythm Society is dedicated to educating our members, but also other healthcare professionals on the problem of sudden cardiac death. The Heart Rhythm Society website, hrsonline.org, has tools available, educational tools, not only for physicians but patients, that are downloadable, and it spends an enormous amount of effort to create these tools in order to provide as much education around the problem of sudden death, and to hopefully have impact on preventing sudden cardiac death, and the appropriate use of tools such as implantable defibrillators and other tools to stratify patients. Thank you.